Hello dear students, welcome to the class on opioid analgesics. So in this class let's learn about mixed agonists and antagonists. Coming to the specific learning objectives, at the end of this class you should be able to classify mixed agonist and antagonist and explain the role of buprenorphine, pentazocine, butorphanol, nalbuphine and their uses as well as adverse effects. So coming to the classification of mixed agonist and antagonist. So before going to the classification, these are the group of drugs which acts as agonist at one opioid receptor and antagonist at another type of opioid receptors. So they have got complex action of on opioid receptors. So it can be classified into agonist and antagonist. So these are the group of drugs which are having kappa analgesic action, means they have predominantly kappa agonistic activity. Examples are nalbuphine, pentazocine, butorphanol, nalbuphine. And coming to the partial mu agonist as well as kappa antagonist, it is seen with buprenorphine. So all these group of drugs have got low ceiling effect, means once the effects, for example, analgesic effect has been reached, above that dose there won't be any increase in the analgesic effect. So that is called as low ceiling effect. So this analgesic activity has got limited efficacy because of the low ceiling effect, and the submaximal, they produce submaximal respiratory depression, and they are less addictive in nature. And one more thing we should remember is none of these drugs should be given if the patient has already used any of the mu opioid agonist, or if the patient is a opioid dependent, because it will reduces the analgesic. As I already said, this analgesic efficacy is limited because of the low ceiling effect. And also in case of dependent individuals, it can cause severe withdrawal reactions. So coming to the nalbuphine, it is the first opioid antagonist which was introduced. It has got kappa agonistic action, it has got lower ceiling analgesic action, and currently they are not used clinically because of the adverse effects like dysphoric effects and psychomimetic effects like hallucination, anxiety, fear, etc. So coming to the pentazocine, which is very important, it is the first agonist and antagonist which is used as an analgesic. It has got mainly the marked kappa agonistic action and a weak mu antagonistic action. So it has got six distinctive characteristics. Those are the analgesic activity which is produced by pentazocine has got lower ceiling effect. The action is produced at spinal level through kappa 1 agonistic activity. And the sedation and respiratory depression are one third to half of morphine. It is also has low ceiling effect. Means uh, the dose, it will not increase much. If you increase the dose, the effect of these sedation, respiratory depression will not be increased even if you increase the dose beyond 60 milligram, etc. And these pentazocine will going to increase the heart rate, blood pressure at the higher doses. The reason being it stimulates the sympathetic system. So there will be sympathetic stimulation by the pentazocine, which in turn leads to increase in the cardiac work. So therefore, if you want to use pentazocine, better you avoid using pentazocine in patients who are having any coronary ischemia or myocardial infarction, because it can worsen their condition. So the fourth characteristic is the biliary spasm and constipation when compared to the morphine, it is less marked, and the vomiting is less, and other side effects are sweating and lightheadedness. There, this pentazocine can also produce subjective effects. It can produce pleasurable effect at lower dose, and as the dose increases, it will going to produce unpleasurable effect. So it also produces psychomimetic effect. It is mainly mediated through kappa as well as the sigma. And with respect to the tolerance and dependence will develop only after repeated use of these drugs. And whereas the withdrawal syndrome is very mild and the drug seeking behavior is less. So if pentazocine is injected to the morphine dependent individuals, it can precipitate the withdrawal syndrome in such patient. And also, the very important thing is pentazocine dependent individuals, if you give naloxone, the two at higher doses, it can precipitate the withdrawal reaction in case of pentazocine dependent individuals. Coming to the pharmacokinetics of pentazocine, it is given orally, it has got considerable first pass metabolism. It has got oral to parenteral ratio of 1 is to 3. It is oxidized and undergoes glucuronide conjugation in the liver and get excreted in the urine. Coming to the T-off is around 3 to 4 hours and duration of action will be for 3 to 5 hours. Coming to the uses of pentazocine, it is mainly, it should not be favored as analgesics for current practice, but it may be used in case of post-operative pains and also to treat moderately severe pains which arises from burns, trauma, fracture and cancer. Mainly in case of chronic pains, the use of pentazocine should be avoided because of the risk of adverse effects like dysphoric as well as psychotomimetic side effects. So coming to the butorphanol, it has got kappa analgesic action. It has got predominantly kappa analgesic action. It is more potent than the pentazocine. So the 2 milligram of butorphanol is required to produce analgesic effect compared to the 30 milligram of pentazocine, and it is also got lower ceiling effect similar to that of pentazocine with respect to analgesia and respiratory depression. And one more thing you should remember is apart when unlike the pentazocine, these butorphanol, the sedative effect is more prominent. The sedation is very prominent. It can also produce nausea and cardiac stimulation, which is similar to that of the pentazocine. Since it stimulates the cardiac activity, these drug, butorphanol, should also be avoided in case of patient with cardiac ischemia. So it can produce subjective effect, psychomimetic effect, which are less compared to pentazocine. BP will not be raised, whereas pentazocine BP was raised. So in case of post addicts, when you give butorphanol, these butorphanol will be recognized as a barbiturates by post addicts and they dislike the use of drugs. And at high doses of naloxone, when you give high doses of naloxone, it can produce mild degree of dependence and withdrawal. And abuse potential with respect to butorphanol is very low. So butorphanol, you should remember this point. Butorphanol is neither a substitute nor antagonize the morphine action. It has got very weak interaction with mu receptor. As I told, it is a predominant kappa analgesic action. So the dose is 1 to 4 milligrams intramuscular or intravenous. It is mainly used in post-operative pains and remember short-lasting pains. Example, the pain arising from renal colic. And it should also be avoided in case of cardiac ischemia because it increases the cardiac activity. So coming to the nalbuphine is a structural analog of naloxone. It has got strong kappa agonist and weak mu antagonistic activity. It is more potent in case of analgesic action compared to the pentazocine. And you should remember here, it has got very less dysphoric and psychomimetic action. At low doses, they do not produce any dysphoric or psychotomimetic effects. At high doses, however, it will produce hallucination, dysphoria, as well as it will produce ceiling effect. So above 30 milligram through intramuscular injection, the response or the effect which is produced by nalbuphine will not be increased. So nalbuphine, this is a very important point. So if you see the pentazocine and butorphanol, they were increasing the cardiac activity, whereas nalbuphine, they do not cause sympathetic stimulation, thereby they do not increase the cardiac activity. So therefore it is safe in patients who are having any cardiac ischemia or myocardial infarction. So it is safe in myocardial infarction. The abuse liability, withdrawal reactions and drug seeking behavior is very low and T of is around 2 to 3 hours. So nalbuphine, so in case of morphine dependent patient, it can produce, the use of nalbuphine can produce withdrawal reaction is mainly due to the weak mu antagonistic activity. So what are the uses of nalbuphine? Nalbuphine is used as for treating post-operative pains and for moderately severe pains. Route of administration is IM, subcutaneous as well as intravenous route. So, and one more thing you should remember is butorphanol is the only drug which is given through nasal formulations. Coming to the case, a 70-year male patient was operated for metastasis to abdomen due to colon cancer. He had a myocardial infarction 2 years back. During post-operative rounds, the patient complains of severe pain in the abdomen. Surgeon asks, is one of the PG student whether pentazocine can be given in this patient. So if you are a PG student, what will be your response or reply to this case scenario? So it is a case of metastasis already operated for colon cancer. So the pain may be due to the operation or due to the cancer itself, and the patient has undergone myocardial infarction 2 years back. So in such patient, if choice is given whether to use pentazocine, pentazocine should not be used because it increases heart rate, it increases blood pressure, and also it increases the cardiac stimulation because it stimulates the sympathetic system. That's why should avoid using pentazocine as well as butorphanol. Instead of, you can give nalbuphine, which is safer in cardiac patients. So coming to the buprenorphine, it is a synthetic thiamine congener. It is highly lipid soluble. It is a mu analgesic action. In addition, it has got kappa antagonistic activity. It is 20 times more potent in analgesic action compared to morphine, whereas the intrinsic activity as well as ceiling effect is low. So the onset of action is very slow with respect to buprenorphine, and duration of action will stay for long, around 6 to 8 hours, and repeated dose will lead to increase in the action for nearly 24 hours. The increase in action is mainly due to the tissue accumulation. And similar to that of the other drug, the analgesia as well as respiratory depression have ceiling effects. And one more thing you should remember is the constipation is very less with buprenorphine when compared to the other group of drugs as well as morphine. And also the postural hypotension is very prominent with respect to buprenorphine. So the sedation, vomiting, meiosis, subjective effects, and cardiovascular effects like vasodilation, which is produced by morphine, is almost similar to that of the morphine. And buprenorphine, in case of low morphine dependent patient, you can substitute with buprenorphine low dose. And whereas if you use a high doses as well as in high morphine dependent patient, buprenorphine can precipitate the withdrawal in highly morphine dependent patients. So the tolerance, dependence, addiction is very low with respect to buprenorphine and also the abuse liability. And they have got drug seeking behavior, and the withdrawal syndrome is almost similar to that of the morphine, but these reactions are very delayed, they are milder in nature, and they stay for long duration of time. So whenever you use an naloxone high dose, it will prevent the effects of buprenorphine, but remember, it causes partial reversal of the effects which are produced by buprenorphine, because buprenorphine will be tightly bound to the opioid receptors as well as the tissue protein. The plasma protein binding is very high with respect to the buprenorphine. And also, when you give a when you give a naloxone, the dose naloxone does not precipitate buprenorphine withdrawal. So why naloxone does not precipitate buprenorphine withdrawal? One of the reason being the buprenorphine is tightly bound to the opioid receptors. So buprenorphine users, it can be used since it has got longer duration of action. It can be used for long-lasting pains like cancer pain, pre-medications, post-operative pains, pain due to any MI, and it can be used for treatment of morphine dependence as an alternative drug to methadone. T-off is around 40 hours. It will be excreted through bile and finally through the feces. The route of administration of intramuscular subcutaneous, it can be given through slow IV, and also it can be given through sublingual route. And very important, it has got high protein binding capacity. So one more thing we should keep in mind while using buprenorphine is, if a patient or a lady is in labor, buprenorphine should not be used, especially in case of if a lady is a morphine dependent. So what happens in such case? It will go for, it increases the risk of respiratory depression both in mother as well as the pregnant lady as well as the neonate. So neonate can also experience apnea of newborn. That's why you should avoid using buprenorphine during labor. So this is the one point you should remember while seeing a lady during labor. So coming to the case, a 28-year-old female with 37 weeks of gestation was in labor. One of the postgraduate asked nurse to give injection buprenorphine as analgesic dose. Unit head or unit chief enters the labor room and asks the nurse what she was loading, and immediately she asks nurse to stop and calls the PG. So here the question is, why the unit head stopped the nurse and what was the reason and what could have happened if it was injected. So as I told, buprenorphine should not be given during labor. So what happens? It will increase the risk of respiratory depression in both mother as well as the neonate. So it can lead to apnea of newborn. So you should avoid using. And also already this buprenorphine, if you give also, it will be tightly bound. So remember, it will be tightly bound to the opioid receptors, and also these naloxone cannot prevent all the actions which are produced by buprenorphine. Again, it will going to be one of the harmful, dreadful complication in both mother as well as the neonates. So that's why you avoid using buprenorphine during labor. So this point you should keep in mind with respect to buprenorphine. So coming to the summary, buprenorphine is a partial agonist as at mu receptor and antagonist at kappa and delta receptor. It is used in the treatment as an analgesic to treat post-operative pain and the management of opioid withdrawal, which is alternative to methadone, and should not be used during labor because it increases the risk of neonatal respiratory depression as well as mother respiratory depression. And even if you use an naloxone, if there is a buprenorphine overdose, it will not effectively overcome all the effects of the buprenorphine because buprenorphine will be tightly bound to the opioid receptors. So coming to the nalbuphine, pentazocine, and desozocine or the agonist at kappa receptor, antagonist at mu receptor, and all these drugs have common adverse effects like dysphoric side effects and psychomotor side effects, which are nightmares, anxiety, and hallucination. And among this, nalbuphine is safer in myocardial infarction because this pentazocine as well as butorphanol will increase the cardiac activity. Coming to the butorphanol, which is predominantly kappa agonist, which produces equivalent analgesia to that of the morphine, and it produces more sedation than the morphine. Thank you.